Welcome to this Step 3 review on the management of common surgical procedures, brought to you by Roadmap to Residency. Today, we focus on the surgical vignettes that show up again and again: hernia repair, gallbladder removal, appendix removal, and lower and upper endoscopy. We are not going to reteach surgery. Instead, we will show you how these question stems are built, which single clue the writers hide in each one, and how to move quickly from the stem to the correct next step. When a stem describes one of these operations, the test is checking whether you know who needs surgery now, who can wait, and which test or timing is appropriate. Keep that lens on. Let us get started. Here is what we will cover. First, how to read a surgical vignette to find the one clue that decides who needs the operating room now and who can be managed without surgery. Second, how to match the right test and the right timing to our 4 operations: hernia repair, gallbladder removal, appendix removal, and endoscopy. Third, we will walk through practice questions and explain why each answer choice is right or wrong, because that builds the pattern recognition the exam rewards. This video assumes baseline knowledge from your question bank and review resources. We are here to sharpen how you take the test. When you see one of these operations, sort the sick patient who needs urgent surgery from the stable patient who needs a scheduled repair or a simple next test. Our first strategy unlocks almost every surgical vignette. Sort the sick abdomen from the stable one. Start with the vital signs, because they are the fastest way to tell whether this patient is heading to the operating room now or can be managed in a planned way. A fever, a racing heart, and a falling blood pressure describe a toxic patient, and the answer leans toward urgent surgery. A comfortable patient with normal vital signs usually needs a scheduled repair or a simple next test. Next, hunt for the danger words that mean the belly has perforated. A rigid abdomen, rebound tenderness, guarding, or free air on imaging all push the answer toward the operating room. When those words are missing and the patient looks well, the writers want the scheduled operation or the correct next test. Run this sick or stable check on every stem. Strategy 2 is the decision at the center of nearly every surgical question. Should this patient go under the knife now, or can the problem be watched or scheduled? Start with those who can safely wait. A small hernia that pushes back in easily with no pain, a gallstone found by chance with no symptoms, and an umbilical hernia in a young child are the classic answers where watchful waiting or an elective repair is correct. When the patient is comfortable with no obstruction or dying tissue, be suspicious of any choice that rushes to emergency surgery. Now flip to those who cannot wait. A hernia that is firm, painful, and impossible to reduce may be strangulated. A gallbladder patient who is febrile and toxic, and an appendix patient with a rigid belly, both belong in surgery now. Spot the trigger words that move a case from elective to urgent. Strategy 3 is matching the right test to the right operation, because these stems usually hinge on the correct next investigation. Start with the gallbladder. For right upper abdominal pain after a fatty meal, the first imaging answer is nearly always the abdominal ultrasound. It is cheap, quick, and very good at finding gallstones. If that ultrasound is normal but the story still fits, the nuclear gallbladder scan is the follow-up. Do not jump to advanced cross-sectional imaging. Next, the appendix. When the diagnosis is obvious in a young man with a classic story and a rigid belly, take him to the operating room without a scan. When the picture is uncertain, cross-sectional imaging confirms it. In a young woman, think of the pregnancy test first and consider ultrasound to spare radiation. Finally, beware the overkill answer. On this exam, doing too much is wrong just as often as doing too little. Let us work through our first practice question, built to test whether you recognize a clear surgical abdomen. A 19-year-old man comes to the emergency department with pain that started near his navel and settled into the right lower abdomen over the past day. He has nausea, no appetite, a raised temperature, and tenderness with guarding at the classic spot. The story and exam are textbook. The question asks for the most appropriate next step. Before you look at the choices, run our sorting check. Is this a sick abdomen or a stable one? And is the diagnosis clear or uncertain? Here the picture is both toxic and classic. Read the 4 options and lock in your answer. Then we will walk through the reasoning on the next slide. Let us break this down. First, spot the pattern. Pain that begins around the navel and moves to the right lower abdomen, with nausea, loss of appetite, fever, and guarding in a young man, is the textbook picture of acute appendicitis. Because the story and exam are this classic, the diagnosis is already made. Now apply the rule. When appendicitis is clear, the next step is to take the patient for appendix removal. You do not need a confirming scan, and delaying only risks the appendix bursting. Answer choice A is correct. Now eliminate the others. Choice B, cross-sectional imaging, is for uncertain cases and only delays care here. Choice C, a barium study of the colon, has no role in acute appendicitis. Choice D, sending him home, misses a surgical emergency and risks rupture. The answer is appendix removal. Here is our second practice question, all about choosing the right first test. A 45-year-old woman comes to the clinic with several hours of steady right upper abdominal pain after a fatty meal. She has had milder episodes before that settled on their own. Today she has no fever, normal vital signs, no yellowing, and only mild tenderness with no guarding. The question asks for the most appropriate next step. Run the sorting check. She is stable, not toxic, with no signs of a perforated or infected gallbladder, so this is not an emergency. The story of right upper abdominal pain after a fatty meal points strongly at gallstones, so the question is really asking which test confirms it first. Pick your answer, and we will reason through all four choices on the next slide. Let us work through this answer. First, confirm with ultrasound. The story is classic gallstone pain, steady right upper abdominal pain after a fatty meal, in a stable patient with no fever and no yellowing. That points to gallstones without infection, and the correct first step is the abdominal ultrasound. It is cheap, quick, and the single best test for finding stones, which is why answer choice A is correct. Now, why the others fail. Choice B, urgent gallbladder removal, jumps to surgery in a stable patient with no infection and skips the confirming test. Choice C, cross-sectional imaging, is more expensive and less sensitive for gallstones than ultrasound. Choice D, reassurance with a low-fat diet, never confirms the diagnosis. The answer is to order an abdominal ultrasound. Now let us make the hernia decision simple, because hernia stems come down to one clean fork. First, reducible and painless can wait. When the stem describes a groin or navel bulge that is soft, easily pushed back in, and not painful, it is an uncomplicated hernia. For most adults, the answer is an elective, planned repair, not a rush to surgery. In a young child, a navel hernia often closes on its own, so watchful waiting up to a certain age is correct. Comfortable and reducible means there is time. Now flip it. Painful and stuck means operate. The moment a hernia becomes firm, very tender, and impossible to push back in, worry that a loop of bowel is trapped and losing its blood supply. Add nausea, vomiting, or fever, and the answer is urgent surgery. When you see those words, never pick watchful waiting. Here is our third practice question, turning from the operating room to the endoscopy suite. A 50-year-old man with no symptoms comes in for a routine visit. He feels well, has no abdominal complaints, no bleeding, and no family history of colon cancer, and he has never been screened. His vital signs and exam are normal. He asks what he should do to check for colon cancer. The question asks for the most appropriate next step. The detail that should jump out is his age combined with never having been screened. This is not a sick abdomen and not an emergency. It is a screening question in disguise. Think about which test actually screens for colon cancer and which choices are the wrong scope or too passive. Choose your answer and we will reason through every option next. Let us break down this answer. First, match the scope to the organ. This is a man who has reached the recommended starting age for colon cancer screening, has never been screened, and is asking specifically about colon cancer. The test that screens the colon is the screening colonoscopy, which looks at the entire colon and can remove growths in the same visit. Offering that screening now is the preventive, whole patient care the exam rewards, so answer choice A is correct. Now the wrong choices. Choice B, upper endoscopy, looks at the stomach, the wrong organ. Choice C, waiting for symptoms, defeats the whole point of screening, which is to find disease before symptoms appear. Choice D, cross-sectional imaging, is not the standard screening test. The answer is to offer screening colonoscopy now. Here is the pearl that ties this video together, a surgical red flag checklist you can run on every stem. First, learn the words that mean operate now. A rigid or board-like abdomen, rebound tenderness, guarding, free air on imaging, a fever with a fast heart rate and low blood pressure, or a hernia that is painful and will not push back in. The instant you see any one of these, the answer shifts toward the operating room, and more testing or watchful waiting become traps. Second, learn the words that mean slow down, symptoms that come and go, a bulge that reduces easily, a comfortable patient with normal vital signs, or no symptoms at all. These point to the correct first test, a scheduled repair, or the right screening study. Sort a stem into one of these two buckets in the first few seconds, and you will get most surgical questions right. That wraps up our review of common surgical procedures for Step 3. Remember the core ideas. For every surgical stem, first sort the sick abdomen from the stable one by reading the vital signs and hunting for the red flags of perforation. Decide whether the patient needs the operating room now or can be scheduled or watched. Match the right first test to the right operation. Ultrasound first for the gallbladder, imaging for the uncertain appendix, and colonoscopy for colon cancer screening. And keep the hernia rule handy. Reducible and painless can wait, while painful and stuck means operate. The best way to lock this in is to drill questions under timed conditions and read every explanation, even the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors. If this video helped, please like and subscribe. Good luck on your exam, and we will see you in the next one.